Hi guys, I'm Dr. Eli. I'm a pediatric emergency doctor, and here is my interesting case this week. We had a 14-year-old young woman who came into the emergency room at, I don't know, 2 in the morning. She was complaining of severe left ear pain, which in my job as a nocturnist, which is an ER doctor who primarily works night shifts, is actually not that unusual. We have patients who come into the ER all the time with severe ear pain overnight, and it's almost exclusively some kind of ear infection. It's generally younger kids who maybe had some cold symptoms, maybe had a low-grade fever before going to bed, and then they wake up in the middle of the night and they're complaining of severe ear pain, generally on one side, sometimes on both, particularly if they have fevers. And when I take my otoscope or my ear scope and I take a look at their tympanic membrane, their eardrum, it's red, it's bulging, there's pus behind it. Boom, diagnosis made. You treat them with antibiotics and move on with your life. It's not that unusual for me to see these patients come into the ER overnight with severe ear pain. It's a little bit less common in teenagers, but it does happen. But this young woman came into the ER that night and was complaining of severe left ear pain. She sits down on the stretcher, and again, as an ER doctor, it is my job to never focus only on the singular complaint that they have. It's my job to make sure that there's also nothing else scary going on as well. So I always have to ask questions. When did this start? What was happening when it happened? Has this happened to you before? Have you been sick at all recently? Any fevers? Any trauma to the area? Have you had any blows to the head? Any car accidents? Anything else that could make me concerned that this pain could be due to a skull fracture, bleeding, or anything else? Do you have a family history of nerve disorders, ear disorders, bone disorders, cancer, anything else that could clue me in that something else was going on? Thankfully, this patient didn't have anything like that, and the story was relatively straightforward. She had no symptoms, she was doing fine, she hadn't been sick, and then she went to bed and she said woke up with a swooshing sound in her ear and severe pain. Now, I'll be honest, I didn't love that, right? No one wants to hear swooshing sounds in their ears, but I figured she had just gone swimming that day. And I asked her, had you been swimming that day? Had you taken a shower and gotten water in your ear? Because sometimes that sort of swooshing, throbbing sound can be due to water that's trapped in the ear canal. Unfortunately, she hadn't. So that was sort of taken off the table. Then I take a look at the full physical exam, which includes vital signs. In this case, she did not have a fever, which made ear infections less common or less likely. She had a normal general appearance in that she was sitting up on the stretcher, didn't seem in distress, and was alert, awake, talking to me, was not in severe pain. And except for her ears, her medical exam looked fine. There's nothing else on exam. With ear infections, I often look behind the ear in what's called the post-auricular or behind the ear mastoid process, which is this sort of bump right behind your ear right here, which is a common and considered to be a severe complication of ear infections called mastoiditis, where sometimes if you have middle ear infections, acute otitis media, it can actually spread through the thin trabecular bone posteriorly or behind that into this meshwork called the mastoid air cells. And those mastoid air cells can get infected. And when they do, it's a huge problem. And these patients often need to be admitted to the hospital for IV antibiotics, sometimes even surgery. Anytime I evaluate a patient with an ear infection or a potential ear infection, I always look in the back of their ear and or behind their ear and make sure that they don't have any sign of mastoiditis. She didn't. The next thing that I do is I look at the pinna and I make sure that this outer part of the ear isn't red, hot, or swollen. That means you could be worried about something called perichondritis, where you have infection of the skin and cartilage of the ear in the area. And then I look at the inner ear canal, or rather the inner part of the external ear canal, for being specific, because if there's redness or pain, drainage, or even tenderness when you press on the tragus, which is sort of this middle part right in here, you press on that, you worry about something called acute otitis externa, also sometimes known as swimmer's ear, where you can get inflammation of the ear canal itself before the TM, the tympanic membrane or eardrum. And that's treated differently than I would treat a middle ear infection. So even before I look in the ear with an otoscope, I'm already evaluating around the ear. Is there mastoid inflammation? Is there perichondritis? Is there acute otitis externa or other signs of infection, inflammation, foreign bodies, piercings, anything else I could evaluate? Nothing in this case. So this swooshing sound, of course, I put this otoscope in this poor young woman's ear, and what do I see? But a bug. I'm I'm gonna be honest, I'm not quite sure what bug it was, but I'm pretty sure I made an audible gasp when I saw it, which the patient didn't love because no one likes their doctor being surprised by something. Um, the good news, it wasn't moving. I don't know if it was dead, but it was definitely there, and it needed to come out. Thankfully, it looked like it was still in front of the eardrum. It didn't seem to have gone through it, and I'm not even going to talk about that. It weirds me out even just thinking about it. But that bug needed to come out. So, how do you get a bug out of someone's ear? Well, step one is actually making sure that it's dead. Because what I really didn't want to do is I didn't want to be grasping at a bug in someone's ear canal that was still moving. Um, Yes, exactly. You're probably imagining what that would feel like, and it would be awful. So what I do is I actually get a little bit of highly concentrated lidocaine, sort of like Novocaine, right? One of those topical anesthetics. And you can get it in a jelly that comes in 2 or 4% concentrations, which is 2 to 4 times as concentrated as we would typically use, like as a lidocaine injection if we were numbing something, like a tooth or a cut or something like that. Um, and I had her lie on her side, and I literally just poured the lidocaine jelly, or this viscous 4% lidocaine into her ear canal until it was literally overflowing with lidocaine. Because whether this bug was dead or not, it was going to be by the time I was done with it. And this lidocaine not only pretty much asphyxiates and numbs and kills the bug, but thankfully it also provides a little bit of pain relief to the ear canal and eardrum itself, because if I'm poking around in that ear canal with tweezers, essentially medical forceps, to get this thing out, I can't imagine that that is as comfortable as a patient would want it to be, or is very comfortable at all. So a little bit of numbing goes a long way when it comes to patient satisfaction. I had the patient lie there for about 5 to 10 minutes, making sure that everything was very numb and very dead, hopefully, not the patient, the bug. And then I literally went back in with my medical forceps and an otoscope, and I was, thank God, able to grasp this and pull it out. And I still don't really know what kind of bug it was, but I'll tell you what, it was as big as my pinky nail, which was much larger than the patient wanted it to be. She was surprised, I think is probably the best way to say that. And you never leave an ER without a doggy bag or some kind of parting gift. So I actually took it and then I opened a sterile urine cup, urine sample cup, and I put it in there, and closed it for her and gave it for her as a parting gift. She didn't want it. And we ended up throwing it in the trash, but not before all the nurses got to take a look at it as well. Um, we weren't done though, right? Because of course the bug is out, but my job is now also to make sure that there's no other injuries, right? So once the bug was out, I actually took some sterile saline and used a small syringe to actually irrigate the ear canal, because the bug is out, but you want to make sure that there's no like parts or pieces or dirt or I don't know, whatever, left in the ear canal. So I took some saline, 2 saline flushes, and I just irrigated the heck out of that ear canal until there was nothing in there but saline. I then took my otoscope and took a look and made sure that the eardrum was intact, because this bug was obscuring the eardrum before, and I don't know if it's intact or not. So you take the bug out, you take a look at the eardrum, and you make sure that the eardrum is still intact, because if it was ruptured, then that, of course, increases the risk for a whole bunch of badness. Then you'd follow up with ENT and all of that nonsense. So thankfully, the eardrum was intact. There was a little bit of irritation in the canal, not surprising. There was a bug in there, but thankfully that was it. It was gone. It was gone. The parents brought up the question about, well, the father who's there brought up the question of whether we should use prophylactic antibiotics in this case, which is to say antibiotics to prevent infection from occurring. And I'll tell you what, I don't know what the evidence is on prophylactic antibiotics when you pull a bug out of someone's ear. I'd imagine it's probably not necessary, because if the bug was removed and the area was cleaned and there's no sign of infection, I can't imagine it's actually a high risk for infection occurring after the fact. But dear Lord, let me tell you, at 3 in the morning, we were not taking that chance, because I looked at the dad and I said, I don't know, she probably doesn't need it. And the patient looked at me, she goes, "I'd feel a lot better." And the dad said, "Yeah, I'd feel a lot better too." And you know what? At 2, 3 a.m., when I just pulled a bug out of someone's ear, I wasn't fighting them about a couple days of amoxicillin. So yes, I put them on antibiotics for a couple days just to be 100% sure that there was going to be no nonsense going on. And they were discharged. And that, thankfully, was the end of that. That was my case of the week. Thanks for listening, and I hope you come back soon.